Hello and welcome to this Q&A from the Fertility Alliance. And today we're going to be talking about NHS funding for fertility. And we're joined by Professor Adam Balen, who is a member of our advisory board. So, Adam, the first thing I wanted to ask you was what actually are the current recommendations about what should be available on the NHS for people with fertility problems?
Well, thank you, Kate, and thanks for asking me to talk about this really important topic, which I think causes quite a lot of confusion and upset, dare I say, amongst some people. So it's very important that everybody knows what's available and how to get help. So there are clear guidelines about the basic investigations for infertility and also the various treatments that are available. And there are funding criteria which do vary around the country, and eligibility criteria that vary as well. But I think the key thing with respect to fertility treatments is that we're still a relatively new specialty. If you remember, Louise Brown is in her early 40s. So I've grown up with assisted reproduction treatments during my career, which spans over 40 years now. And so we have gathered a lot of evidence, and that evidence informs clinical practice. And in the UK, NICE, which is the National Institute for Healthcare Excellence, I can never remember, the acronym has changed a little bit, but essentially it publishes guidelines. The first guidance was published over 20 years ago. It's been revised and it is in the process of being further revised based upon the evidence behind how to investigate problems that cause infertility, where those investigations should be performed, how they are funded, and how the treatment should be provided. And I think it's very important everyone thinks about IVF, but there's much more to fertility care than simply providing IVF treatment. But if we take a step back, the guidance indicates that couples should be investigated after they've been trying to conceive for a year or more. However, if you have a fertility problem, or if you think you have a problem, then you can be investigated as soon as you seek help from your GP. And it's very important to appreciate that. So if, for example, you have irregular periods, it suggests that you're ovulating irregularly. You do not need to wait a year. You can seek help straight away, and you should ask for help and appropriate investigations. Similarly, if you have a history of having, for example, had a pelvic infection, that might affect fallopian tubes, or if as a man you've had problems with puberty or growing up, you may have had mumps after puberty, those things can affect sperm count. So if you have anything that you feel might have affected your natural chance of conceiving, it is appropriate to seek help and advice straight away. Go to your GP, ask to be investigated, ask to be referred to a clinic that specializes in fertility issues. So that would usually be your local hospital, which will have a gynecology service, and there are usually gynecologists with a special interest in infertility. The basic investigations include checking hormones, checking an ultrasound of a woman's pelvis to look at the womb and ovaries, and checking a semen analysis. And that will then guide further investigations and potentially treatment. Now, the treatments could range from stimulating regular ovulation if a woman is not ovulating, to investigating the fallopian tubes and potentially doing surgery to correct damage or blockage around the fallopian tubes or other conditions in the pelvis, such as endometriosis, or hormone treatment for some male conditions if there's a low sperm count due to a hormone deficiency. I'm not going to go through all the different treatments, but the point I'm trying to make is that there are treatments before you get to needing IVF, and those treatments are funded and available universally on the NHS and should not be restricted. The guidance, however, does place some restrictions on age and body weight, um, which can influence funding criteria, and that will vary a little bit around the country as well.
And Adam, should you always be able to have those kind of investigations, even if you don't necessarily qualify for IVF? So if in your area, for example, IVF is restricted to people, people can't have it if they've got a child from a previous relationship, should you still be able to have the investigations?
That's a very interesting question, and the answer is again, it varies around the country because there are restrictions in some places who say if you're not eligible for fertility treatment, you're not eligible to be investigated. Personally, I think that's wrong. I think everybody should be able to have the basic investigation so at least they know what their problem may be. Of course, there has to be um, cost effectiveness within the NHS, um, but you can do the fairly simple investigations, I would say, cheaply, so that at least people have an idea as to what the problem may be and how to seek help and what they might need. And then they may have to self-fund if they're not eligible.
And when it comes to IVF, what are the recommendations about what should be available?
So if you need IVF, then the guidance in NICE is that for those under the age of 40, there should be 3 cycles of IVF provided. So 3 full cycles. So the IVF cycle involves stimulating the ovaries, extracting eggs and fertilizing them in the laboratory to create embryos. So the embryo is the fertilized egg. And surplus embryos can sometimes be frozen and used without having to go through the full process. And so the guidance does enable a treatment to be funded, including the use of fresh and frozen embryos. And for most people, 3 cycles should give an extremely high chance of achieving a pregnancy, easily 70 to 80% chance of having a baby from IVF, if you factor in the use of frozen embryos as well. So many people don't need the full 3 cycles.
And what is that recommendation actually based on? How do they decide on the 3 cycles?
Well, based on the evidence actually of the cumulative chance of conception with repeated cycles. I mean, IVF success rates have gone up over time, um, but again, expectations have to be appropriately managed. So if you take people at peak fertility, say in their late 20s, early 30s, in good clinics, the chance of having a baby with the transfer of a single embryo is easily 50%, even higher. Uh, but it's never 100%. But for some people, it's only 20 or 30%, which, may be influenced by age or other health factors. So repeated cycles may be required. I think what many people also don't appreciate is that the chance of conceiving naturally for those who don't have fertility problems is maybe only 20% each month of trying anyway. So IVF is always a boost because those people who need IVF inherently have probably less than a 5% chance of conceiving naturally. So some people say, oh, 20, 30% doesn't sound like very much, but it far exceeds the natural chance, which is why the treatment is required.
So why are so many areas not following that guidance? If that's what people are meant to get, why aren't they getting it everywhere?
Because sadly, our health service is not fertility friendly. Um, And I think that's a disgrace, really, because there's clear evidence that fertility treatment is cost effective. And if you want to look at it on purely economic terms, which I don't like doing, but if because I believe that people should be cared for and looked after, but from purely economic terms, it has been clearly shown that the contribution, the economic contribution to society made by children born as a result of fertility treatment far outweighs the cost of the treatment. In other words, growing up, contributing to society by working and just, whatever you may do in your life will always outweigh the cost of IVF. And we put pounds, shillings, and pence on IVF, which certainly can cost thousands of pounds, but we don't put pounds, shillings, and pence on other medical treatments, which are also very expensive. But nobody knows the cost of being in hospital for a day, for example, for whatever it might be. But everybody knows the cost of IVF. But it is cost effective. But it's an easy way of avoiding. Um, Paying out because health services are stretched and the local care boards are stretched. And so they see that it's easy to avoid paying. And this is an historical problem, which I'm afraid is born out of all of the controversies around the early days of IVF, when some people felt uncomfortable about the fertility treatments themselves, but that's long in the past. I mean, millions of healthy children have been born as a result of IVF around the world, and it is a well-established treatment that obviously brings joy and the ability to have families to so many people.
Presumably, at a time when we've got a declining population, it could be particularly useful to be spending more on IVF.
I think that's a very interesting point. Absolutely. I mean, we in the UK at the moment are below our replacement rate. The number of children per family is 1.5 and the replacement rate is 2.1. So many countries around, or most countries around the globe actually are not replacing the population.
What about same-sex couples and single people? How easy or not easy is it for them to access fertility treatment on the NHS?
Again, it depends where you live. I mean, it's something I've pushed for in Yorkshire, and we do have funding for same-sex couples to come through for using donor sperm, so that's same-sex female couples. And we've been pushing for funding for same-sex male couples who, of course, need surrogacy arrangements as well, so it's more complex. Where we are single women are not eligible for fertility treatment. I believe, and I'm sure you probably know better than me, Kate, that I think in some parts of the country it is available.
What can people do if they're not able to access the treatment that is recommended? Is there anything they can do if they live somewhere where there isn't the treatment they think they ought to get?
The straight answer is probably not. I mean, it is difficult. People appeal, but in my experience, appeals are very rarely successful, sadly. But if you live in an area where you're not eligible for treatment, and you moved somewhere else, you usually have to live somewhere for a period of time before you then become eligible. So it's a terrible situation. It's the so-called postcode lottery, and it's completely unacceptable in this day and age.
What would you actually like to see in the future? What would your dream be if you could have whatever you liked in terms of fertility care?
Well, I'd like to be out of a job. I'd like to see, I'd like to see people conceive naturally. I mean, that's the whole fertility education side of things. I know that if people were supported to have families when they're younger, then there'd be less need for fertility treatment. But that's perhaps a slightly facetious answer because I appreciate there will always be fertility problems. There'll always be people who have disorders of ovulation, either because of PCOS or other problems, or endometriosis. There are always going to be health issues that require fertility treatment. So there needs to be equality around the country. There needs to be equality not only with respect to the provision of treatment for those who don't have children, but I don't see why those who already have a child, many of whom actually are in new relationships, so they may have a child from a previous relationship, why shouldn't they be enabled to have children? Any child who's wanted is going to be brought up in a loving relationship and adds to society in so many ways. I think we need to get away from this and become more family friendly as a society. It's important for the future of the nation, really.
Adam, thank you so much for that. It was really interesting to hear your views on this and to understand more about how funding works in different areas. So thank you for joining us for this Q&A today.
Pleasure. Thank you very much, and it's great to see all the really important things that the Fertility Alliance is achieving.